Hi, I'm Michael Ritchie. We're going to be talking about advanced hemodynamics in critical care. I always liked, when I start thinking about hemodynamics, I always think it goes back to the number one equation. I think the most important equation is the oxygen delivery equation because I think it explains everything in critical care and especially for hemodynamics. So we're going to discuss the oxygen delivery equation, we're going to discuss hemodynamic breakdown, and then we'll go into LV hemodynamics versus RV hemodynamics. Here's kind of a triad that I think about is that you have somebody that's in organ failure and you're working towards resuscitation. In order to do resuscitation, you need oxygen delivery. And organ failure is usually a decrease in oxygen delivery that's leading to the organ failure. And so if you can resuscitate them, is that you're trying to improve oxygen delivery to your organs to get them out of failure. It is the most important equation for critical care. The formula is oxygen concentration times flow. So your oxygen concentration is going to be your CaO2 and your flow is your cardiac output. So CaO2 is 1.34 times hemoglobin times saturation plus 0.003 times the partial pressure of oxygen. If we break that down further, then oxygen delivery is cardiac output times 1.34 times hemoglobin times saturation plus 0.003 times the partial pressure of oxygen. The main components to delivering oxygen are then going to be cardiac output, hemoglobin, and oxygen saturation. Partial pressure of oxygen is so low, you're multiplying it by 0.003. It's going to be pretty negligible for you to be able to do anything with it. So cardiac output, hemoglobin, oxygen saturation, anytime you're trying to increase oxygen delivery, that's what we're really going to focus on is what can I do to increase these things if I don't feel like I have enough oxygen delivery. Hemoglobin is just a protein molecule in the red blood cells. It carries oxygen from the lungs to the body tissues. Oxygen saturation is that fraction of oxygen saturated hemoglobin relative to the total hemoglobin. These are important, but cardiac output is just really important because you can have all of these things optimized, but if you're not actually delivering that to the tissues, it's not going to make a difference. So most of what we do in resuscitation is to improve our cardiac output, to improve oxygen delivery. Breaking down cardiac output. So cardiac output is heart rate times stroke volume. And then stroke volume is further broken down into three components, and those components are going to be preload, contractility, and afterload. So this is how you're going to improve cardiac output. You can either improve the heart rate, you can optimize preload, optimize contractility, or optimize afterload. That's how you're going to be able to improve that cardiac output, which improves your oxygen delivery, which is going to help resuscitate these people that are in organ failure. The first thing we're going to talk about is preload. So I always like to think that there's the actual definition, the traditional definition that typically gets taught, and then how we traditionally measure stuff. And then I'm going to go into some other ways we can measure stuff since we're getting into more like advanced hemodynamics. So the actual definition is the stretch of the cardiac myocyte at the end of diastole. So it's the stretch of that muscle at the end of diastole. Typically, when people start talking about preload, they think about it as your ventricular filling or the volume in the left ventricle. If we're talking about left ventricular hemodynamics, the volume in the left ventricle at the end of diastole, or your LVEDV. We usually, when they say, hey, I would love to measure our preload, people are wanting to get like a CVP, or if they have a swan in, they'll get a pulmonary artery occlusion pressure, or some people call it a wedge pressure or pulmonary capillary wedge pressure. Those are the traditional measurements. Whenever I think about preload, because it's the stretch of the cardiac myocyte, if you think about it as a spring, so you have this spring, and if you stretch it, if you kind of pull it down and release it, it'll kind of spring back to where it is. The further you stretch it, the harder that kind of spring back to where it was, and you get more and more force. If you overstretch that spring, it's going to stretch out the wires, and then you're never going to kind of be able to get it back where you need it to be. And that's really how preload is, especially when you refer to it to the Starling equation, is that as you pull back that spring, you're going to get more and more force going forward. But if you over distend it, then you're not going to be able to get that force because you've over distended your spring. So these stretches kind of correlate on the Starling curve, as you can see, is that you have B and C, you've improved that stretch, you're getting more and more force, and then as you overstretch it with D, you've over-distended it, it's not going to be able to get back where it was, and you start getting on the descending limb of the Starling curve. Here's another example, if you want to look at it in terms of muscle units, is that as you kind of pull those actin myosin units apart, is that you're going to get that optimal stretch. But if you overextend it, you're going to uncouple it, and then you're not going to be able to get back where you were, and you're not going to be able to generate as much force. So you want preload to maximize that interaction, but if you have too much preload, you're going to come off the curve, you're going to uncouple your muscle fibers, and then you're not going to get the squeeze that you need. Why is pressure unreliable? Why am I talking about having to do advanced hemodynamics and doing these other types of things? So we use CVP a lot of times, and we use wedge. So our pulmonary artery occlusion pressure, or wedge, is a better measurement than CVP, because CVP is on the right side and wedge is on the left side. If we look at our pulmonary artery occlusion pressure, it is a surrogate for our left atrial pressure. And our left atrial pressure is a surrogate for our left ventricular end diastolic pressure. And our left ventricular end diastolic pressure is a surrogate for our left ventricular end diastolic volume, which is what we're talking about, is that you have that volume that creates that stretch on the ventricle. The reason that we've shown that CVP is unreliable, that wedge can be unreliable, is we're assuming whenever we do these as surrogates that our pressure and our volume are equal. So that if you go up in volume, you go up in pressure. If you go up in pressure, you go up in volume. If that were true, then you would see a linear relationship like you see here, where as you go up in volume, you have an equal increase in pressure, and it'll be this straight line that's going out. This is not true. If we look at our pressure volume relationship, and we look at our pressure volume loop, when we look at our cardiac pressure volume loop, the filling curve, which is the bottom part of this loop, is actually what it looks like with it. So you have this filling during diastole, and then you have an isovolumetric contraction, and then your aortic valve opens and you have an ejection curve, and then your mitral opens when your aortic valve is then closed, and you have this isovolumetric relaxation, where then your mitral valve opens, and then you start the process over again whenever your mitral opens and you start filling. The area inside this loop is your stroke volume. So you fill it up, like I said before, you're then squeezed between a closed mitral and a closed aortic, and then your aortic opens, and then it closes, and then you relax on a closed aortic and mitral, and then that's why you have isovolumetric relaxation, and then your mitral opens and you start filling. Here's a really good example. So if you look at this, the orange shows your end diastolic pressure volume relationship. So as your LV fills up with volume, that's how your pressure is going to respond to it. As you can see, it's not a straight line. It's very much a curve where you're adding a lot of volume. You don't get a lot of changes in pressure until the very end of the curve, whereas you add volume, you start getting increases in your pressure, much different than you do at the bottom of this curve. Additionally, if they have diastolic dysfunction, as you see, they bump up to the green line. So now they have this increase in their pressure with no increases in their volume. Their ventricle is stiffer. So for that same exact volume, they have different pressures. So if you look at if someone gets diastolic dysfunction, is they'll have the exact same amount of volume as the other person, but their pressures will be significantly higher. So again, this kind of shows you how pressures just aren't really good indicators of what you can look at, and that you actually need to be looking at that cardiac myocyte stretch. You need to be looking at that end diastolic volume, and that end diastolic volume is what's going to create that stretch, and that the pressure is just going to depend on person to person. Here's another good example. So you have your normal heart, and then you have somebody in the middle that has left ventricular hypertrophy, and then you have the person that has dilated cardiomyopathy. Now, in this situation, one of them has a very thick LV in left ventricular hypertrophy, and so they have diastolic dysfunction. They have very high pressure, but not very high volume. And then the people with dilated cardiomyopathy, they end up not being able to squeeze that volume out, so they get more and more and more volume in there, which will then raise the pressure. So actually, both of these people would have the exact same LVEDP, or they would have the exact same wedge, when they have wildly different volumes in there, because one of them has a pressure problem and one of them has a volume problem. So it's another reason to show you why looking at pressures have not been reliable whenever we start doing studies on patients. In this example, we have systolic versus diastolic dysfunction. you have the exact same stroke volume, but you have very different left ventricular and diastolic volumes. So in the left side on the diastolic dysfunction, you could actually give them volume and that may increase stretch. Whereas if you try to give volume to the people with systolic dysfunction, you'll actually worsen this, you'll overdistend them even more, and they'll get worse and worse stroke volume. So completely different ways that you would treat these people based on where they are on the curve. In fact, if you look at systolic versus diastolic dysfunction and you look at your wedge and your left atrial pressure and your stroke volume and your cardiac output, LV volume, contractility, preload, you look at all these measurements and you look at how systolic and diastolic look, is that they actually have very little in common. They both have elevated left atrial pressure and elevated wedge, but they have a lot of differences in their LV volume. They have a lot of differences in their contractility and their preload. You could even argue that somebody with cardiac tamponade has more in common with somebody with diastolic heart failure than diastolic heart failure has in common with systolic heart failure. This brings me to lusitropy. So the whole idea of this stiff ventricle, we talked about the diastolic dysfunction and the stiff ventricle, is that lusitropy is the term for cardiac relaxation. Cardiac relaxation is an active process, so it requires ATP. So what happens is ATP activates the channel on the sarcoplasmic reticulum. It allows the influx of calcium, and then the influx of calcium drops your intracellular calcium, and you end up releasing your actin and your myosin, and you end up with cardiac relaxation. So if you don't have ATP or you have ischemia, your heart gets very stiff because you end up with not being able to relax because you don't have the ATP in order to do it. Here's a good example of different curves on your left ventricular end diastolic volume and your left ventricular end diastolic pressure for your end diastolic pressure volume relationship. Is that if you increase the compliance, if you make it easier to relax, they're going to get further and further, drop their curve to the right, like you're seeing here. And as it gets stiffer and stiffer, it's going to go up to the left. And we saw that in somebody with diastolic dysfunction. So as somebody gets diastolic dysfunction, they're going to bump that up because they're losing that ventricular compliance. They're losing that lusitropy. So your preload is your left ventricular end diastolic volume, is kind of a way to think about it. And the question is, how do you measure it? Like, what are you thinking whenever you're trying to manipulate it? So we're going to talk about how to manipulate it and then how you can appropriately measure it. So two things I want you to be aware of when we're talking about optimizing preload is stressed and unstressed volume, and then mean systemic filling pressure. So our venous system, we end up having like a venous reservoir. It's an amount of our venous blood that we really don't use. About 85% of it is considered unstressed volume. And that puts us about 15% with stressed volume. So that stressed volume is what's getting pushed over into the right atrium. All right, so when we're talking about mean circulatory filling pressure versus mean systemic filling pressure, mean circulatory filling pressure was the mean pressure of the entire circulatory system when the heart is stopped. So this was tested by Guyton years and years ago, where they actually did it with dogs, and they said, all right, when the heart is stopped and all the pressure kind of equalizes out, what is that mean circulatory filling pressure? And it was around 8 to 12. Mean systemic filling pressure is the assumed pressure at the venual level with pulsatile flow, so whenever the heart is not stopped. And they're supposed to be about the same. But your venous return, what we found out, has nothing to do with what your arterial pressure is, but it has to do with the pressure gradient between your venules and your right atrial pressure. So your mean systemic filling pressure, or your venual pressure, minus your right atrial pressure will give you a gradient. That gradient is what wants to push that venous blood back to the right atrium. If you look here, if your venous return is dependent on you having the difference between your mean systemic filling pressure and your right atrial pressure. If your mean systemic filling pressure equals your right atrial pressure, you're not going to have any venous return because you're not going to have a pressure gradient. And this is why we saw back in the day, whenever everyone would just resuscitate people to a right atrial pressure, a CVP of 8 to 12, that we weren't seeing those benefits because the venules have more capacitance and they stretch a lot easier than the right atrium. And so with all that volume that these patients were getting is that the venual pressure would change very little, whereas the right atrial pressure would change a lot. So as you gave people volume, your right atrial pressure would go from like 0 to 5 to 8 to 12, whereas your venual pressure would go from 8 to 12 to maybe up to 14. And so you'd really drop that gradient, and you're not really getting blood being pushed to your right atrium. So while there may be a lot of volume in your venous side, it's not being pushed forward. It's not creating that stretch on the myocytes that's going to optimize your preload. So your mean systemic filling pressure, like you can see here, if you use it compared to your stress volume and unstressed volume, is going to be your mean systemic filling pressure minus your right atrial pressure. And it's that stress volume that's being pushed with that gradient to your right atrium. So that gradient is going to tell you how much volume is going to get into your ventricle to be able to do the filling. Now, if someone goes into distributive shock where they vasodilate out, is that they will drop that gradient, because now they're vasodilated, they drop the gradient. The new gradient will be lower. They're going to have less volume getting to the right atrium. So we give volume in order to increase that gradient and kind of drive that gradient back whenever they do it. Another thing you can do is give vasopressors, and what vasopressors do is it's going to squeeze that down, and it's going to increase the stress volume and decrease the unstressed volume. So if you treat it with fluid, a lot of times you're not going to get what you need. You may get some benefits, but what happens is that your unstressed volume, you increase your stress volume, but you also increase your right atrial pressure. So you've increased your mean systemic pressure, but you also increase your right atrial pressure. So you don't really change the gradient very much. So you don't get as many benefits as you need. And so if you just keep giving fluid and fluid and fluid, you're not optimizing their preload, because the preload is depending on that gradient. Whereas if you treat with vasopressors, you're going to increase that stress volume because you're squeezing down your venous reservoir and you're creating more stress volume from unstressed volume. And that's going to increase that gradient back. So there are a lot of benefits to using vasopressors, and you can use vasopressors if you need. And I think a lot of people treat vasopressors and say, I failed because I had to put this person on vasopressors. Well, I disagree with that. I think vasopressors definitely have their uses, because then you're not giving a lot of fluid. You're not going to ruin that mean systemic filling pressure to right atrial pressure gradient. And by improving that gradient, you're going to really improve preload. So you can give some volume, but I think treating with vasopressors is going to increase the stress volume, increase that gradient, improve your preload. So CVP, like I said, is frequently used to measure LV preload, which is just way off, because CVP is actually a surrogate for your right ventricular end diastolic volume, which doesn't necessarily mean anything about your left ventricular end diastolic volume. If you have RV dysfunction or pulmonary hypertension or something before the left ventricle, then your CVP becomes even less reliable. So you have your wedge pressure. That's a little bit closer, and we kind of talked about this. Is your wedge pressure estimates your left atrial pressure. But again, you're using a pressure to estimate a volume, and we kind of talked about how that doesn't work well. You're making a lot of assumptions about the patient's lusitropy, how much the LV relaxed, how stiff the LV is, and so you're not necessarily getting an accurate picture of what their volume status is. You're just getting what their pressure status is. You can measure preload by an echo. So what we found is that if we can look at, when we're doing diastolic dysfunction, we can look at our E to A, which is the velocity of our inflow during diastole. So our E stands for early diastole, our A stands for atrial kick, so they have to be in sinus rhythm in order to have an E and an A. And if you have a stiff ventricle or you have diastolic dysfunction, that E velocity becomes higher. And then you do something called tissue Doppler. And tissue Doppler is where you actually measure the velocity of the muscle of the heart. And the muscle of the heart, when it relaxes, you can do the tissue Doppler and you can measure how fast it relaxes. And that's how you get an E prime. In the left side, you can do both you want to do it at the mitral annulus, or the base of the mitral valve. And so you can do the septum side, or you can do the lateral side. And what it does is that you can then take your E velocity and divide it by your E prime velocity, add 4, and that's a good estimation of someone's wedge pressure or their LVEDP. Another thing you can do is just directly measure it. So a lot of times when someone's getting a left heart cath is that they'll stick a catheter across the aortic valve and they'll just directly measure what the pressure is in the left ventricle. That's going to be a direct measurement. Again, that doesn't necessarily tell you what the volume is in your left ventricle or enable to really tell you what the stretch is of the myocytes, but what it's telling you is what that pressure is that you can directly measure, as opposed to using a surrogate when you put in a right heart cath and get a wedge. So those are kind of your options. You can do your left ventricular end diastolic volume, which is very difficult to measure. So a lot of times we use these surrogates. We use a wedge pressure or a pulmonary artery occlusion pressure. We use our left ventricular end diastolic pressure, or we can estimate it on echo with E divided by E prime plus 4. Again, your preload is dependent on venous return and lusitropy. So you have to have the heart relax and open up, and then you actually have to have the volume to get in there to create that stretch. This is how I do it. So I like to use the VEXUS criteria. This was originally described post-cardiac surgery, but is a really good way of saying, do I have too much preload in the venous side? So whenever we're talking about it on this standpoint, it's not necessarily going to tell you exactly how much volume is in your left ventricular end diastolic volume, but it can talk to you about what's on your right side. So this is a way you can look at ultrasound, and you're looking at kind of the volume on the venous side, and that way you're equating volume to volume, and I think it's just more accurate measurement as opposed to trying to use a pressure to estimate a volume. This looks at your IVC. So if your IVC is greater than 2 centimeters, then you move to the next step. And this is where you use Doppler. So if you have too much volume in your RV stretches. As your RV stretches, it dilates out your tricuspid valve, and you end up with tricuspid regurg. So whenever you have that tricuspid regurg, if it's bad enough, it starts going backwards during systole. So you get kind of that reversal of flow. And if it becomes significant enough, you can actually see reversal of flow in your hepatic vein, in your renal veins, and you can even see that pulsatility in your portal veins. And so this is what it's showing is step 2, you would look at your hepatic vein Doppler. And you should see the blood should always be going from the liver to the right heart. If it's going the opposite direction, so it should be going below the yellow line. And if it's going the opposite direction, it's going to go above the yellow line. And so if you see that reversible flow, then you know you have so much volume on the right side is that you've dilated out that tricuspid valve, and you have that reversal flow with it. And if it's severe, you'll get this sinusoidal pattern because every time during systole, it's going backwards and then diastole going forward, and you just get a back and forth motion, which has been shown to worsen right heart function. The portal vein is just going to be, it should be a continuous flow on top of the yellow line. And if you start seeing pulsatility in your portal vein, that's a sign that you have that reversal of flow. And then in the renal vein, you're looking at the bottom of the yellow line. I typically, for all these, will go mid-axillary. I think it's the easiest. So you would look at your IVC kind of mid-axillary, and then you would be able to get your hepatic vein. And then you usually go posterior axillary, drop down to rib space. You'll be able to see the portal vein, and then drop down again to look at the kidney and see if you can look for the renal vein. But if you see pulsatility below the yellow line in the renal vein, then you know that you have reversal of flow. And if you meet criteria, you can have grade 1, grade 2, or grade 3 congestion. So it is very objective to say, no matter what I think that person is up to, I can tell you there is too much volume on the venous side. They have way too much volume. They have pulsatile flow on the right side, which they shouldn't have. Now, it could be due to having pulmonary hypertension, and that they can't get the blood from the right side to the left side, or if they have some sort of RV dysfunction. And your LV could still not have that much volume in it. So that's where you have to be a clinician, and you have to say, is this happening because they're overall hypervolemic, or is this happening because I just can't get all of that venous blood to the left side, and I need to focus more on how to get the blood from the right side to the left side. All right, so how I measure preload with pressures is that ideally I would have like a swan in or a pulmonary artery catheter, and I'd be looking at both the CVP and the pulmonary artery occlusion pressure or wedge pressure. And the reason for that is that if they're both elevated, if your CVP is higher than it should be and your pulmonary occlusion pressure is higher than it should be, most likely it's a volume problem, and you can start looking at volume removal and diuresis. If your CVP is normal and your wedge is high, then that's probably a pressure problem in your LV. So that doesn't, you're not necessarily hypervolemic, you have a pressure problem. You can focus on how to get the pressure down, which is where you're gonna like try to increase lusitropy, increase that cardiac relaxation, or decrease your systemic vascular resistance, both of which will drop the pressure in your LV. If that's the only one that's elevated. And then if your CVP is high but your wedge is normal, then it's an RV problem. It's not a volume problem, and you need to either support the RV or reduce your pulmonary vascular resistance so you can kind of drop that pressure on the right side. So having both of those pressures can be helpful, but looking at those pressures independently, you can run into a lot of problems if you're using them to estimate a volume. The next thing we're going to talk about is contractility. Contractility, we're going to go the same thing we did with preload. There's going to be the actual definition, the traditional definition, and then the traditional measurements. So the actual definition is the contraction of the myocyte independent of preload or afterload. And that's important, is that it is how much it contracts independent of what the preload conditions are or the afterload conditions. That's true contractility. We typically look at ventricular function, which is going to be how the contraction is at a given preload and afterload, or a given filling volume or systolic pressure. And then that's going to actually be function as opposed to contractility. And the traditional measurement we use, which is ejection fraction, looks at the LV function. So this is what we traditionally use for contractility is EF. Again, if you're really talking about how well the heart squeezes, is that we reference three different things. We talk about contractility. We're usually referring to function, and then another thing we can look at would be performance. So contractility, like I said before, is the contraction of the myocyte independent of preload and afterload. Function is the contraction of the ventricle dependent on preload and afterload. And then performance is the ventricle's ability to do work, so the ability to do force over a distance. So you can look at how the heart is doing based on looking at these three different things. And there's multiple different ways to measure it, and we're going to go over all of them. So in terms of the pressure volume loop that we looked at before, we're not talking about the end-diastolic pressure volume relationship. We're looking at the end-systolic pressure volume relationship, or that diagonal line that goes tangent to the corner of your where you have your isovolumetric relaxation, and then you have your where your aortic valve opens and is able to eject on the curve on that one. As your contractility changes, your ESPVR, your end systolic pressure volume relationship, will actually change. So as you get worse and worse systolic function, that line will drop down to the right, and you'll get it's going to be less and less of a curve on there, and you can actually measure this distance. You can measure your change in volume with change in pressure and be able to get a contractility by understanding what the value is of your end systolic pressure volume relationship. Another way you can measure it is you can directly measure what your change in pressure over change in time is. So if we look at what the left ventricular pressure does over time, is that it fills and you get a certain pressure, and then you have that isovolumetric contraction where you have a large increase in pressure, and then you eject, and then you have this isovolumetric relaxation where you have a drop in pressure, and then you start the filling process over again. So if you focus on what the change in pressure over change in time is, of the isovolumetric contraction is that if you directly measure the LV by putting a catheter in there, is you can actually directly measure what this change in pressure over change in time is, or delta P over delta T. And that's going to give you what your contractility is, which is a more accurate measurement of how well your heart is functioning because it's independent of preload and afterload. Here's your normal. Normal is going to be greater than 1200, and this is in millimeters of mercury per second, and then reduced is less than 800, and then severely reduced is less than 500. This isn't done frequently, but we're looking at getting more and more tools to be able to look at this because it's going to give you a better indication than looking at function, which is going to change based on preload and afterload conditions. Another way that we can look at our contractility or the way we squeeze is to look at function like we talked about. One way we do it is called fractional shortening, and that's done on the echo, and oftentimes it's done in the peristernal long view like you see here. So you measure what the left ventricular ventricular diameter is, and that you look at that diameter during diastole, and you look at that diameter in systole, and that change in the diameter goes through a formula, and you end up being able to estimate a fractional shortening, and then that fractional shortening will then be able to be equated to an EF. The better way to do it on echo is to actually directly measure what the EF is using what's called Simpson's biplane. And the idea is that you have these little discs, and each disc, you know the area of it. You add up all the discs at the end of diastole. You add up all the discs at the end of systole. You look at the change in that volume, and the change in that volume will give you the EF. People are starting to use more and more of what's called global longitudinal strain, and we look at how well the heart changes, and so how well it can squeeze, and it can give you an idea of what your systolic function is. It's more reliable than EF, and so it'll tell you how much it's changing during systole, and it's given in a negative number. So if it is negative 20 or more negative, then that's generally normal function, or around negative 18. And if it's less than that, then that means you have some where your walls of your ventricle are not changing or are not squeezing as much as they should, and that is an indication that they have some sort of contractility issue, and it'll give you an idea of how well the LV is functioning, and has been shown to be a little bit more reliable than looking at EF. Another thing you can do is MAPSE, which stands for your mitral annulus plane systolic excursion, where you look at the base of your mitral valve, which is your mitral annulus, and you look to see how far it moves during systole. It's not frequently used. You'll see, we'll go over kind of on the right ventricle equivalent of this, which is used more often, but you can use MAPSE. You may hear people refer to it. You can also use S prime. So we talked about tissue Doppler when we talked about doing diastolic dysfunction, and we were looking at E prime. So if you look how much your mitral annulus moves during systole, is that velocity that it moves, and tissue Doppler will give you an idea of how much it's squeezing. And so I always like to use 10. So if your velocity is greater than 10, then that's typically normal for systolic function. If it's less than 10 for an S prime, then that's typically abnormal. And then if we're talking about performance, or the ability, the heart's ability to do work, is that the number one we use is the left ventricular stroke work index. Your left ventricular stroke work index looks at the area of your pressure volume curve as opposed to just the diameter. The diameter is how you got your stroke volume. The area in this loop is how you get your stroke work. Stroke work is a pretty good indicator of how well your heart can function, because it's the ability of the heart to do work as opposed to just trying to figure out squeeze or trying to look at the other variables with it. It's a little bit more complicated of a formula. What it is that it's your MAP, which is the pressure at the end of the left ventricle minus the pressure at the beginning, which is your left atrial pressure, and then you multiply it by your stroke volume. times 0.0136, and then you divide it by body surface area to get index. So left ventricular stroke work index. It is given as a value if you have a pulmonary artery catheter in. And then the other one can be done through echo, and that's your myocardial performance index, and it'll look at performance. And it looks at, again, it's looking at that isovolumetric contraction time, and it's also looking at your isovolumetric relaxation time. And you add up those times and divide it by your ejection time, and that will give you a myocardial performance index. And that can be done by looking at with Doppler during echo. So here's how all those things together. If you want to look at contractility, you can look at your ESPVR. Normal is going to be less than 1.8. Abnormal is going to be greater than that. If you look at your change in pressure divided by change in time, greater than 1200 we talked about versus less than 800, it's going to be abnormal. Fractional shortening is less than EF. So fractional shortening, normal is greater than 28%. Abnormal is less than 28%. And then your EF, as you know before, 55 to 65% versus less than 40 being abnormal. If we look at global longitudinal strain, just in this table to make it easier, I did it as absolute values. So if the number is greater than 18%, then you're looking at normal versus if it's less than 16%, you're looking at abnormal. And then we previously talked about MAPC and S prime. And this one that typically will actually show that greater than 6 is considered normal when dealing with S prime, and then less than 6 would be abnormal. I usually try to remember 10, even though that's a little bit of an overestimation, because I also use the same numbers when dealing with diastolic dysfunction for E prime whenever I'm looking at someone that has diastolic for the two sides of it. So it's an easier number to remember, but the actual value is going to be greater than 6 and then less than 6. And then your left ventricular stroke work index and your myocardial performance indexes are listed. So in measuring cardiac output, we've gone over preload. Here's a list of all the different ways you can measure contractility. Again, when we're talking about contractility, you have to know if you're referring to function versus contractility versus performance, but all of these can kind of give you an idea of how well the heart is working in terms of being able to squeeze. The easiest one is still EF. It's mentioned in echo. It's easy to reproduce. So we'll still use it, even though it's not technically contractility, it's function. It's going to differ depending on what the patient's preload or afterload is, but it has to do with the inotropy or the heart's ability to squeeze. This is how I measure it. Like I said before, I typically will look at EF just because it's the easiest to find, it's the easiest to reproduce. It is not contractility, it is function, but it will give you data to be able to kind of help out in deciding what you need to do or what you need to manipulate in order to improve oxygen delivery. The next thing we're going to talk about is afterload. Afterload, I think, can be difficult for some people because it's very different than what you think about. So the actual definition and the traditional definition are very different. The actual definition is the ventricular wall stress that occurs during systole, whereas the traditional definition is the load or the resistance the heart must overcome during systole. And then the traditional measurement is the SVR, or systemic vasoresistance, which really focuses on what the heart has to push against and doesn't really focus on what the actual wall stress is. And so if you look at afterload for what the actual definition is, you can really see how we do certain things the way we do because we're trying to manipulate the afterload through the actual definition. We have our normal Starling curve, which is in yellow. And if you decrease afterload, you'll move it up. And if you increase afterload, you'll move it down. And that's because what it does is you'll have better stroke volume because you're pushing against the less resistance. And so you'll kind of move it up. And then it's easier for you to eject that stroke volume. And then you'll have less pressure because you'll have better stroke volume on there because you're pushing against less afterload. Same thing, the exact same curve if you look at your afterload versus your LV function. And this is like I said before with function, is that it's dependent on afterload in preload conditions. So if you change the afterload, you can really change what the EF is. I always say that the best way to treat heart failure is to give them a little bit of septic shock, because you're gonna cause that vasodilatation. It's going to be much easier for the heart to eject. That EF is going to look considerably better. It didn't change how well the contractility of the heart, it just made the EF better because it made it much easier to unload because it doesn't have as much resistance to push against. So as you can see here, as you decrease the preload, the EF gets better because you've made it easier for the blood to go forward. Here's another example. So if you look, like I said before, is that if you change afterload, it's not going to change the contractility. So the ESPVR is a way of measuring contractility. So that is independent of preload and afterload. So as you change the afterload conditions, you're not going to change that ESPVR, but you are going to change other things with it. So normal is in blue. If you increase afterload, you're going to really narrow that pressure volume loop. You're going to make that pressure significantly higher. And then if you decrease afterload, you're going to kind of stretch out that pressure volume loop. You're going to make that pressure lower. You're going to be able to eject more volume because it's going to be easier to eject because you're pushing against less resistance. The actual definition is based on Laplace's law. And it looks at wall stress, which is T in this equation, and it is the transmural pressure, which is the pressure across the ventricular wall during systole, and then the cavitary radius, and then so it's that transmural pressure times the radius divided by 2 times the wall thickness. And what that's going to do is make you see that it has much more to do what's inside the LV than just what that arterial pressure is that you're pushing it. So it's not necessarily that you're just pushing against something, it has a lot more variables to it. And so if you look at your wall thickness, which is H, and then you have in orange there, you have your diameter of the LV, and you would do half of that, which would be the radius. And then you have your transmural pressure, which is the difference in pressure between inside your ventricle and outside your ventricle. And that's going to be able to get you your wall tension. It is a better explanation for how positive pressure or negative pressure affects afterload. So your transmural pressure, which is your LV pressure minus your intrathoracic pressure. So in this example, we're going to look at how positive pressure affects someone's afterload, is that you're looking at the pressure across the ventricular wall. So if a normal LV pressure during systole is 100, and your intrathoracic pressure is positive pressure now because you have them on a ventilator and you have them on BiPAP and it's plus 10, is that the transmural pressure, or the pressure across that ventricle, becomes 90. So you have less transmural pressure than you did if you were under negative pressure. So it actually decreases the afterload because it affects the transmural pressure in Laplace's equation. So the determinants of that ventricular pressure, like what decides that ventricular pressure is 100 or whatever value it is going to also be dependent on your arterial system. So the determination of your arterial system is going to be this equation, right? The one that people are familiar with, where you have your pi times your pressure, or change in pressure, times your radius to the 4th, divided by 8 times the viscosity of the fluid times the length of the tube. This will be what affects your flow. And if you're looking at the pressure, which is the pressure in your left ventricle, then it is going to be the one on the right, where it is Q8NL divided by pi r to the 4th, where you have very little changes in your radius of your tubes. Then it's going to create a much higher pressure in there. And this is how you're going to get that first pressure, which is just part of the equation, because you're also talking about what the radius is of that LV cavity, what your wall thickness is. Another thing to consider is so much of what we do post-MI or dealing with heart failure is that we want to prevent remodeling. And so remodeling will cause your left ventricle to stretch out, and it'll cause your walls to thin. And both of those will increase afterload because you're increasing that radius and you're decreasing that wall thickness, both of which increase afterload. So a lot of medications that we're prescribing is to prevent that remodeling so that we don't worsen that afterload with left ventricular dilatation and wall thinning. Acute changes to afterload. So something where very acutely, all of a sudden you have big changes in afterload is that if you have hypovolemia or dehydration, hemorrhagic shock, cardiogenic shock, decompensated heart failure, all those will lead to increased afterload, whereas decreased afterload are going to be things that are going to cause like vasoplegia or dilatation, sepsis, septic shock, acute pancreatitis, burns, post-MI cardiogenic vasoplegia, post-bypass vasoplegia. And then chronic changes. So this is not going to be something acute. This is just people that are going to be prone to high afterload and stress on the heart. Is this whole list here where you start talking about chronic systolic dysfunction, diastolic dysfunction, aortic stenosis, chronic hypertension, diabetes, aging. All of these can lead to different changes in the determination of Laplace's law that will make your afterload higher. I like to think as afterload is like a dam. So you have a dam, you have water that's kind of rushing over it. And as you change the height of that dam, it makes it easier or harder for that water to go across. So if you raise the dam, you're going to have less volume that's going forward. You're going to have much more volume left behind the dam. And so if you increase afterload, you're going to increase the volume in your left ventricle, and you're going to have less stroke volume or less release going across because you're raising that dam up and not allowing it to go forward. Whereas if you drop the dam down, now you're letting everything rush forward. And this is why whenever you have septic shock or some sort of distributive process, you're vasodilating, all of a sudden it's very easy for all of that blood to go forward, and your EF is going to look great because you're just allowing all of it to rush forward because you've lowered the dam. We measure afterload, like I talked about before, systemic vasoresistance. This is based on Ohm's law, which was V equals IR. If you do it for the heart, you end up with, anytime you're dealing with resistance in the body, it's change in pressure divided by flow. So the change in pressure on the left side is going to be your MAP minus your CVP, and then your flow is going to be your cardiac output, and then we multiply it by 80 to change it from wood units to dynes. So here's your formula: change in pressure divided by flow times 80. Normal is 800 to 1200 is an easy way to remember it. What it does mean is that your cardiac output is directly proportional to your MAP, and it's inversely proportional to your resistance. So if you make them have less resistance, then they should have more cardiac output. If you increase the resistance, they should have less cardiac output. So you can manipulate how someone's cardiac output is by what you're doing with the systemic vasoresistance. So now we're left with what we typically look at with afterload is their systemic vasoresistance. Again, it's not necessarily the best way to look at it, because whenever we look at systemic vasoresistance, oftentimes we think about what the arterial system is doing or how clamped down the arterial system is. Whenever it's a bit more complicated than that, because we're also talking about the LV diameter and the LV wall thickness and the transmural pressure. But it's a nice way to look at it to get an idea how to manipulate it from a cardiac output. Really no other great ways to measure it. This is kind of how you're going to do it: normal range versus abnormal. If it's too high, it's going to be harder and harder for the LV to eject, and you're going to have decreased function. That leaves us to how we're breaking down our hemodynamics, our cardiac output. We have heart rate times stroke volume. Our heart rate, just to go over the 5 tropies of the heart, chronotropy would be our rate through the SA node. Dromotropy is our heart's conductance, and that's through the AV node. And then bathymetropy is your cardiac excitability. So how excited the heart gets. If we say something like, oh, dopamine is arrhythmogenic, what we mean is that it's bathymetropic. It increases cardiac excitability. We already talked about lusitropy, which is cardiac relaxation, which is going to help out with preload. And then inotropy is going to be the contraction or contractility of the heart, and that's going to deal with your contractility or EF. So these are kind of the 5 tropies of the heart and how they relate to cardiac output. Next, I'm going to talk about RV hemodynamics. So we're not necessarily going to go back over all the preload, contractility, afterload concepts, but I'm just going to talk about how RV hemodynamics are measured. whenever we do this. So you can say, all right, this is different. There's different ways that we can manipulate RV hemodynamics compared to LV hemodynamics. First thing, again, we're going to talk about is preload. Again, preload, it's the ventricular end diastolic volume. So for the right side, it's the right ventricular end diastolic volume as opposed to the left ventricular end diastolic volume. People still use CVP. It is obviously a better marker. CVP is a more accurate marker of RV-EDV than it is of LV-EDV, but we've already discussed how a pressure isn't reliable compared to a volume because they're not linear whenever you look at their relationship. I still use Vexus whenever I'm trying to look at RV preload, is that I'm looking for that tricuspid regurg, I'm looking for that congestion. If I see that reversible flow, I know they have too much preload. If you see just complete collapse of the IVC and they're hypotensive, then you can start thinking about that they don't have enough preload. But I typically will grab an ultrasound, I'll go to the bedside, and I'll be looking to evaluate right ventricular preload by actually looking at the volume, by looking at the IVC, and that way I'm using a volume to equate a volume as opposed to using a pressure to equate a volume. Next, we're going to talk about contractility. Contractility is very different in the right heart because we typically don't measure EF. It's just hard to do. You can try to look at kind of the area change. It's easier to do in the TEE than a TTE, but again, the value isn't often given. It's harder to reproduce, so we use other values to look at how well the RV is contracting. The number one that we use is TAPSE. So TAPSE stands for tricuspid annular plane systolic excursion. So it's the base of the tricuspid valve, which is the annulus. Plane because it's in 2-dimension. It's in your apical 4 view. And then you look at how much it moves during systole. So in systolic excursion, the idea is that during systole, because the RV free wall shortens, it doesn't contract centrically, or it actually just shortens on this plane, as you measure how much it shortens during systole. If it shortens more than 2 centimeters, that's normal. If it's less than 1.7, that's abnormal. So TAPSE is often given as a value on echo, and so that way you can really get an idea of how well someone's heart is functioning. Again, TAPSE is more of function. It is dependent on what their preload and afterload conditions are. If there is a swan in place or a pulmonary artery catheter in place, there's 3 other ways that you can really look at the function. PAPI, which stands for pulmonary artery pulsatility index. That gives you a really good idea of how well the RV is contracting. And if you think about it, if you look at the formula is your PA systolic minus your PA diastolic divided by CVP. So, and the numerator, which is PA systolic minus PA diastolic, if your RV is not functioning well, you're not going to have a lot of contractility. So you'll have a really low contractility because the heart's not functioning well, and so that will make the number low. And if your heart isn't contracting well, it's not emptying the RV very well, and so your RV is going to fill up with volume, and your CVP is going to go up. So the higher your CVP, the lower the number because it's on the denominator. So PA systolic minus PA diastolic divided by CVP. The numbers, you can actually use the exact same numbers that you would use for TAPSE. Normal's greater than 2, abnormal's less than 1.7. A lot of people are going to reference TAPSE or PAPI whenever dealing with mechanical support. So in all the cardiogenic shock literature, what they found was if your PAPI was less than 1 in cardiogenic shock, you needed an RV support device. So either an RVAD or an RV Impella, or you needed to go on ECMO. So you'll hear people say, I really need to focus on, is the PAPI less than 1? That doesn't mean 1 or 1.1 is normal. It just means that if it was less than 1 and they were still in shock, they needed some sort of RV support device or some sort of RV bypass, whereas actually abnormal is less than 1.7. Another one is the CVP to wedge ratio, or CVP to PaOP ratio. Normal CVP is 0 to 5. Normal kind of wedge is 10 to 15. So a nice way of looking at it would be that your CVP should be 25 to 30% of your wedge. If it is a higher ratio than that, then that means your RV is not doing a very good job of being able to get that volume from the right side and put it into the left side. So if your CVP is greater than 50% of your wedge or of your PaOP, that means you have some sort of RV dysfunction going on. And this has been looked at in multiple different papers as a way of identifying people with RV dysfunction. And the other one is right ventricular stroke work index, which is similar to the left ventricular stroke work index. It looks at how well the RV is, its ability to do work. One thing that's unique about the pressure volume loop in the right ventricle is that you don't actually have isovolumetric time periods. So you don't have isovolumetric contraction, you don't have isovolumetric relaxation. Unless they have chronic RV dysfunction. So if somebody has chronic RV dysfunction, it will start to look like the LV pressure volume loop, and you will actually have the isovolumetric contraction and relaxation. Right ventricular stroke work index, again, it's the pressure after the right ventricle, which is your mean pulmonary artery pressure, minus your pressure at the beginning of it, which would be your right atrial pressure, times stroke volume, times 0.0136, and then you divide it by body surface area to get index. Abnormal is going to be less than 7. So if your right ventricular stroke work index is less than 7, then you know you have some sort of RV contractility issue. Multiple papers have looked at right ventricular stroke work index versus CVP to wedge ratio versus PAPI as a way to identify who's going to actually have RV dysfunction and who's going to be the sickest. PAPI won out to say that PAPI was more reliable than the other two, but you can kind of look at all of them and get an idea of how well the right heart's doing. But if you could only look at one, PAPI is the one that's been shown in like whether or not to put in a VAD or all these different or mechanical support. It's done the best compared to the other two. And then last, we're going to talk about afterload. Here's the example of all the different ways you can measure RV contractility. And then we're going to start talking about afterload. So afterload, again, it's based on Ohm's law, V equals IR. Anytime we're dealing with resistance in the body, it's change in pressure divided by flow. If we're talking about the pulmonary vascular resistance, or the PVR, your flow is the exact same, it's cardiac output. But your pressures are different. So it's the pressure at the beginning of the system, which is your mean pulmonary artery pressure, minus the pressure at the end of the system, which is your left atrial pressure, and then you divide it by cardiac output. Now for PVR, we typically don't multiply it by 80. We don't change it to dynes. We leave it in wood units. Normal, which has just been changed by the guidelines, used to be normal would be less than 3 wood units. We've now changed to be less than 2 wood units. So here's an example. You have a patient that has a MAP of 63. Their PA pressures are 41/25 with a mean pulmonary artery pressure of 32 and a CVP of 20. And you have a wedge of 16 and a cardiac output of 4.27. So if you do the math on there, is that you have a PVR of 3.74 wood units. And then what that does is it tells you that they have increased pulmonary vascular resistance, or they have high RV afterload. So it's going to make it much harder for the RV to pump forward. The RV hates afterload. It's thin. It's not designed to push against pressure. And so if you're running into problems, if you look at these values, it can give you an idea of why the RV is struggling. It's because it's having to push against higher pressures than it's usually having to push against, because it has more resistance. You can estimate, so if you don't have a swan in and you want to get an idea if you think somebody has increased afterload, one of the things you can do is you can estimate what somebody's PA pressures are using echo. And this is using a simplified Bernoulli's equation. And here's all the different math to be able to go through it. But the end equation is just 4V squared plus CVP. Your V is your tricuspid regurg velocity in meters per second. You square that, multiply it by 4, add your baseline CVP, and you're going to get an estimated pulmonary artery systolic pressure. Your TR max is typically done in your apical 4 view. You're going to use your continuous wave Doppler. You're going to get whatever you think your tricuspid regurg velocity is. So in this example, it's 2.9 meters per second. And then you have to get what your baseline CVP is. We estimate it on echo. So if your IVC is less than 2 centimeters and variable, we estimate it at 5. If it's greater than 2 centimeters and variable, we estimate it at 10. And if it's greater than 2 centimeters and non-variable, we estimate it at 15. Using simplified Bernoulli's equation with those numbers, 2.9 squared times 4 plus 15 will give you 49. Any PASP greater than 40 means that you have elevated, you have probably have pulmonary hypertension, and you're looking at most likely having increased afterload, or it's harder for the RV to push against. I like to use the mean pulmonary artery pressure to map ratio if you have a pulmonary artery catheter in. Again, similar to the CVP to wedge ratio, is that your mean pulmonary artery pressure should be like 1/4 to 1/3 of your map. If it's greater than 50% of your map, then something's wrong. It means that you have too high pulmonary pressures, and you're starting to get into some danger. So normal is less than 33%, abnormal greater than 50%. If you start getting 2/3 systemic, if your mean pulmonary artery pressure is almost 2/3 your systemic pressure, the mortality is extremely high, and oftentimes you really need to do some sort of intervention, or they're going to be declining towards increased mortality and worsened outcomes. So again, when we're looking at RV function, when we're looking at preload contractility and afterload, these are all the different ways that you can measure preload contractility and afterload. Here's your way of measuring your right ventricular afterload, and then deciding between precapillary and postcapillary, which is a whole different lecture. This will decide whether or not these increased pressures are actually due to the pulmonary vascular itself, or due to a left heart disease, or post-capillary after the capillary beds in the lungs, that's deciding why there's increased pressure in the pulmonary system. And again, this is how you're going to look at the different tropies and how they're going to relate to cardiac output. And so hopefully you guys can see is that in order to resuscitate somebody, in order to get somebody out of organ failure, is that we're working on the oxygen delivery equation. And so much of that oxygen delivery equation is cardiac output. And if you can understand not only how to measure the different components of cardiac output, but how to manipulate the different components of cardiac output, you can really make a difference in terms of resuscitating them out of organ failure. Thank you very much.